punching and it's just, there's no give to your bottom, they will do an episiotomy if needed. They used to say, you know, do the episiotomy, it's more clean cut, you know, you don't have the jagged edges, you know, to repair like you do with a laceration. But who's to say that you actually even need one? You know, women do get away with, you know, pushing and letting the head sit on the perineum and then stretch things out, and then they can deliver without anything at all, an intact perineum, you know?
So they just stop.
No, they have bandage scissors. So on their delivery table, they have, you know, suture scissors, all their instruments, and bandage scissors. So they cut the umbilical cord with bandage scissors. They don't, you know, do any damage, no sharp edges. So with an episiotomy, you don't want to go in with a pair of sharp scissors and actually run the risk of, you know, hurt the baby. So you take the bandage scissors and you just snip, and then usually the amount of force that's on mom's perineum will cause everything else to go. You have first degree, which is like a very small laceration, all the way to fourth degree. So it's through it's second degree. They don't count the amount of stitches because it's just like a continuous stitch. But you can have like a, you know, a tiny little bit that, you know, that they do, or completely ripped, yeah, all the way down. And then with those, the fourth degree, you can have some bowel, you know, issues later on. Maybe your second baby might want to have, you know, consider doing a C-section if your repair was that bad.
So can this in turn cause a fistula?
It depends, you know, how you heal.
Yeah, can that make you not be able to have that conversion next time?
Not necessarily. I mean, would you want to risk having another fourth degree? It's something you would talk to about with your physician. Most people that you know, a primary C-section, oh, how come? I had a really bad delivery last time, I had a fourth degree. Okay, it makes sense, you know what I mean? You don't want to, you know, risk it again. You know, if they're, you know, they talk with their physician about it and they're fine, then okay. You know, but, question?
I don't know, I was just, you know, thinking about how you're saying it's not routinely done.
Yeah.
But is that more because they're pushing the C-sections?
What, the episiotomy?
Yeah.
No, not necessarily. It's just because as the baby's, you know, crowning and you're pushing, you might get away with just the first degree laceration.
So they would rather risk that laceration than
do it a piece. Yep. Because you could be pushing and I just cut it a piece just because I think you might need one, and maybe you didn't need anything and you're completely fine. Or you had just like a tiny little tear and, you know, you were okay. If you know, you can see mom's perineum like stretch and bulge as the baby's head's putting pressure on it, and it's physician's judgment, I guess, as to when they would cut. But as you're watching it and you see like it's trying, and nothing's working, mom, you know, legs are back, her pelvis is open wide, and it's still not giving, then yeah, they'd be like, okay, you know, and they'll snip. But you don't want to do one if you don't really have to.
And if you're doing 90, will they cut?
I think at that point you are so overwhelmed with the sensation that's in your perineum that I don't think you would even notice that. Yeah. Afterwards, though, they would give you local, an injection, and repair. That you may feel a little bit because that whole like that shock is gone. But I think at that intense moment where you're like, I don't think you even pay attention to that. It's like real quick and it's like, whoop, done. Yeah. So with delivery of the baby, you're going to suction the mouth and the nose once the head's out, because you want to try to clear as much of the secretions away as you can. So suction the mouth first and then the nostrils. Once the body's delivered, we're going to cut and clamp the cord, and we're going to suction the mouth and the nose again. Baby is, here it says handed off to the nurse or the pediatrician. We put the babies, as long as they're okay, on mom's belly. and we'll dry and stimulate the belly, the baby on mom's belly, and they can do their pictures and they can see their baby, and we're looking at them, and it's at this point that we're gonna assign the first APGAR. How is this kid? Is it picking up? Is it crying? You're looking at muscle movement, you know, all that stuff. So you're, you know, watching the baby, and then after about your 1 minute, then you can take the baby over to the warmer and then dry off some more, do the footprints, the weight, and all that stuff over there. So, and then the mom is, you know, still up in stirrups to do her repair if she has one. Third stage, when the placenta is when it separates and delivers, so it can last up to 30 minutes. There have been moments where, you know, it's past 30 minutes, it's not coming out, they'll go in and try to manually extract the placenta. Sometimes mom has to go back to the OR, they will put her under sedation. If she has an epidural, they'll just dose the epidural some more, and they go in sometimes with a curette and try to scrape whatever's in there. They'll have an ultrasound to make sure that they have everything out, because you don't want to leave any pieces in there because it could cause infection or a hemorrhage. But yes, so you give mom 30 minutes, see what happens, and if not, then it's up to you to try to get it out. But again, you're never going to pull on the cord. You're actually going to go up and try to separate them. Fourth stage, also known as recovery, begins when the placenta has been delivered. It can last anywhere from 1 to 4 hours, or until mom's vitals are stable. Usually she'll stay back in the delivery room for about an hour for recovery, and then she goes out to postpartum. Her vitals during that first hour back in the DR are every 15 minutes. We're checking the fundus, we're checking bleeding, vital signs. When she goes out to the floor for postpartum, they're still going to do that frequently and check on her frequently, especially in that first few hours. So anywhere from 1 to 4 hours is her recovery time. They'll do them every 15 minutes in the delivery room. Yeah, because, you know, okay, yeah, she feels firm, and, you know, I have Pitocin running. I go back and I check her fundus, and all of a sudden I have this, like, big blob of clot that comes out. Oh, what's going on, right? So you want to make sure that you're in there, and they have electronic cuffs, so I mean, you're cycling them every 15 minutes, or you're still in there checking her bleeding, checking her fundus. How does she feel? How's her pain? Is she breastfeeding, not breastfeeding? So you're constantly in there. Average blood loss can be anywhere from 250 to 500 cc's, okay? And that can drop her blood pressure, so you want to keep an eye on that, and increase her pulse rate. Okay? Her uterus must stay contracted to compress the open vessels of where her placenta was, okay? That's why we're giving the Pitocin. If mom's breastfeeding, that helps. The fundal massage, okay? So she should feel firm. It should be at or below her umbilicus, okay, midline. And then also her first hour after delivery is still critical because she can still bleed heavily. So even though she's in the delivery room, her hour passes, everything looks fantastic, she gets to postpartum, she can hemorrhage over there. Okay, so you still want to make sure that her uterus is nice and firm. Changes in labor, mom's body systems are all affected by this. Physiologic changes can be seen either directly or indirectly, depends. And nursing interventions are important and need to be provided in a timely manner. So yeah, everything's affected by mom. You know, if her psyche, her eating habits, her bowel and bladder habits, you know, everything. So we just need to be available to her and provide her with the care that she needs, you know, when she needs it. Changes that can occur physiologically are a slight increase in blood pressure, diaphoresis, dry lips, offer her, you know, if she has a chapstick or ice chip, increased respiratory rate, try to get her to control her breathing, possible hyperventilation, calm down, you know, look at me, it's okay. Her whites might go up to 25,000, and she may have spontaneous voiding or bowel movement. Yeah, it happens. Okay. Questions? Are you? No questions? All right. we are going to, okay, we're gonna do chapter 17. That's also part of the newer material. And then, we can do, lunch afterwards if you guys want to take lunch at that point. Okay? So chapter 17 is the newborn at risk, acquired and congenital conditions. All right? So it's inborn errors of metabolism, okay? They don't always show up at birth. Sometimes you'll see them later on. And there are tests that they use for screening for these errors, and it's required by law and in most states. Okay? It's a PKU, exactly. And speaking of, here it is. So, all states screen babies for PKU. And just as a side note, interestingly enough, I had this patient yesterday. She came in and she wanted to do her cord blood banking. So she, you have banking, which is private, so you're paying for it. And then you have donation, which is kind of like the Red Cross, where you can donate your blood, your cord blood, and whoever needs it can use it. So she was doing private, and in the private, I guess they have these new options now. You can collect the blood, you can collect the portion of the cord itself, so you're collecting tissue, and then they had, she had to pay extra for it, their own newborn screening that they do in addition to what the hospital is required to do. So when the baby gets stuck for PKU for the hospital, they would also collect a sample for the cord blood company, and they would do their own screen and test for whatever they're going to test for. So it's kind of like a backup check kind of thing, except they're paying for it, and then they can have an idea like, okay, so because of all these things that are popping up with cord blood usage, you can MS, use the stem cell therapy, whatever, and they can do MS, they can do this, they can do that. I'm guessing that since they're screening for this stuff, that they can say, oh, well, we picked up this on your newborn, you can use your stem cells for this. Who knows? But you may, but that was just interesting that they did that. I'm like, what are you talking about? We do that test ourselves, so you don't need that. No, we're paid for them. Are you sure? They wanted it, Okay. So PKU. So it's about ingesting proteins, all right? So you have this increase, like you can't metabolize the proteins properly. So you have an increase in your system. And this, in accumulation, can lead to severe mental retardation. If they catch it early enough, you would follow specific diets, limiting your protein, and then you would get, weekly, blood checks, or depending on how severe it is, and follow your levels. I know one girl who did have PKU, and she was on a very, very strict protein diet. So she could have one slice of turkey that day, you know what I mean? Because that's the only amount that she could actually metabolize properly, and that's it. So she would go weekly and get her finger stuck and do the PKU test, and they would follow her levels. They caught it early enough where she's now in college and functioning. She does require some assistance. She's not 100%, but she's able to talk to you. She's able to shop online. She's able to function as a young adult. So if you catch it, then you're able to actually keep it to a minimum. If not, you can have brain damage. So they do the test in the nursery, they poke the baby's heel, collect 4 dots of blood, and send it off. If anything comes back positive, you would hear about it from the pediatrician. So they say no news, good news. So if you hear anything back, then they would be able to tell you, okay, hey, you came out positive, for the PKU, something, we're gonna have to watch the baby's digesting. And that affects everything. Meats, dairy, cheese, everything. There's protein in a lot of things, so you have to be careful. Galactosemia. So this newborn has a deficiency of the enzyme needed to convert galactose to glucose. Milk substitutes are prescribed, such as Nutramigen. Breastfeeding is discontinued, okay, because it contains lactose. Screening all newborns is required in most states, and if untreated, it can lead to failure to thrive, cataracts, jaundice, cirrhosis of the liver, sepsis, and mental retardation. Okay? So I don't know if you guys have ever seen Nutramigen. It's a formula, and it has, if you have it in a bottle, so if, you have what you see, if you go like this and nothing happens. With Nutramigen, there's an oil base to it, so when you go like this to a bottle, you actually see the formula slosh back and forth and the residual of the oil left behind. Kind of, yes, exactly. So, apparently it smells really bad going in, it smells really bad coming out, so that's what I've heard. But yes, that's special formula. Hypothyroidism, it's a congenital hypothyroidism that results in an error in the metabolism caused by maternal iodine deficiency. If left untreated, it can lead to hypothermia, poor feeding, lethargy, jaundice, and cretinism. So the infant has a very large protruding tongue, the thick lips, and just like a dull appearance, just kind of, it's a required test in all states. All right. Maple syrup urine disease. It's a disorder of amino acid metabolism. So there's elevated levels that can cause cerebral edema and CNS symptoms such as seizures. The body fluids have a sweet odor to them. So your urine, saliva, that kind of thing, yeah. From what I've learned, this comes from like Lancaster area, like back in that area, like the Amish. You see a lot of it. But the one family that, actually two families that came in, it was on the dad's side, and they were African American, they weren't Caucasian. So I don't know if there was, bloodlines that came down, but it does run in the families. And she didn't have anything, he had it, and then they had to make sure that they tested the baby for it because it could go, continue on. So, I'm like, what do you mean maple syrup? Like, what are you talking about? They're like, it just, things smell very, very sweet. Okay. Hyperbilirubinemia. You have physiologic jaundice and pathologic jaundice. So there's abnormally high levels of bilirubin in the blood. It's caused by an altered metabolism and excretion of the bilirubin due to an immature liver. Okay. So when the babies come out, their livers are not as mature as ours. And as the red blood cells break down, they have to excrete that, and they're just not up to functioning 100%, so they can't keep up. So things tend to build up in their system, and then they look like little glowworms, okay? The way that we try to get rid of it is to feed them often, so every 3 hours. We want to make sure that they're, peeing and pooping. Some babies will need to have phototherapy, so they'll put them on billy beds and try to get rid of it. If they have slight jaundice and it's not very bad and they're discharged to home, the pediatrician may say to them, put the baby by a window, closed window, in the car seat with the diaper on, and let them sunbathe, because those UV lights will help get rid of that jaundice. It'll break it down. But with some kids, it's just very, very bad. I remember this one little girl, when I was doing my peds rotation, was, I don't know if you can see it clearly, the color of, remember those glowworms, the toys, the glowworms? They look like fluorescent little bugs. That's exactly what she looked like. Everything, like all of her skin, the whites of her eyes, everything. She was so bad. Yeah. I mean, like she looked like a highlighter. That's how bad it was. The poor kid, she had, tubes everywhere, felt bad. They'd bring her out to the nurse's station so she'd have some company. They'd put her in a little wagon. Yeah, it was sad. So, you have conjugated and unconjugated. Conjugated means that it's turned into water soluble and it's excreted. Unconjugated means it's reabsorbed and then recirculated in the bloodstream. Yeah, exactly, yes. Yes, we'll get that, yeah. Bilirubin will peak around day 3 to 5. So vaginal deliveries, you may not see it as much because they're discharged by day 2. So if the baby's gonna have any issues and they're a C-section baby, yeah, they're around till day 4, so you might actually see it there. What they do now is they will, with every assessment, so 3 times a day, they're gonna flash the baby and monitor how they look, head and chest, exactly. And if their levels are rising, they let the pediatrician know, they might have to send off the serum, and if it comes back as high, then the pediatrician will say, hey, can we Billy lights, or, we have to make sure we watch, that kind of thing.
I know in Georgia they have the chart.
Yeah.
The percentile.
Okay.
So if it's like, they're like 3 days old and their level is 3.2, that's normal.
I believe so. Yeah, every hospital is a little bit different, yeah. Ours, if they're, what was it? 3 and under? Is okay?
Yeah, they're really
Yeah, something like that, yeah.
And then I think 4 to.
It's like,
And then red is.
yeah, something like that. High levels can actually stain the brain, causing long-term neurological issues called connectors. So pathologic is excessive breakdown of your RBCs due to your maternal antibodies passing through the placenta to the fetus. Right? So you'll see this happen with Rh negative moms. All right. So the other one, your physiologic is your body did it. Pathologic is outside. So Rh negative. Did you guys go over this earlier?
Yeah, but I was kind of,
Okay. So picture this. You are Rh negative. Your husband is Rh negative. Your baby is Rh negative. Right? You're Rh negative, your husband's positive. You have a 50-50 chance of having either a negative or positive baby, right? So say your firstborn is Rh positive, right? At 28 weeks and within 72 hours, 48 to 72 hours post-delivery, you need to have a RhoGAM shot. The reason why you do that is because while you don't have maternal fetal mixing of blood in pregnancy, once you deliver, and you have, some mixing that happens there. If I'm Rh negative and the baby's positive, my body will now make antibodies against Rh positive blood. So when I get pregnant again, and my second baby's Rh positive, my body sees that as foreign and wants to get rid of it. So I will fight it and break down its blood cells. So it can lead to fetal anemia, it can lead to fetal death. That's what this is talking about, okay?
and that's pathological.
Pathologic. Okay? So it's important for moms who are Rh negative to get their RhoGAM. And some would even go as far as to say if mom's had, she's Rh negative and, experiences a loss, maybe it's too early, whatever it is, but you really don't know what the baby's blood type would have been. Prophylactically, you have, you get your RhoGAM just to cover, all areas. But again, it's something you talk to with your doctor, yeah.
But if the mom is positive and the baby's negative,
It's fine. Right.
It's
It's only the Rh negative. Right.
Because she's not fighting.
Right. Right. Go figure, right? So yes, so it's important for mom to get her RhoGAM, and I haven't seen it in many, many years, but they have this procedure called a PUPS procedure. So if mom, she has some exposure to Rh positive blood, she's making antibodies, and they noted that there was something going on with the baby, they would do kind of like an amniocentesis and take a sample of blood from the umbilical cord and send it to the lab, and they could see what the baby's blood levels are, and if they were too low, actually transfuse the baby while inside mom's belly. Yeah, so, but I haven't seen it in a long time, but, it is very dangerous, yeah, it's very dangerous, but, it's important for them to make sure that they go for their care, make sure that they don't they're supposed to go. So treatment for jaundice, like I said, is feeding, babies pooping in pain, the phototherapy, and in extreme situations, an exchange transfusion, you know. Hypoglycemia, so this is a plasma glucose level less than 40. So 40 is the cutoff for babies, whereas ours is like 70. Newborns born to diabetic moms are at increased risk, okay, because they're used to getting this level of glucose all this time, and all of a sudden, whoop, you're on your own, see ya, you know. So signs of hypoglycemia are lethargy, hypotonia, they're jittery, they don't eat well, tachypnea or apnea, they sweat, they have a really, really shrill cry, their temps are off, they can have seizures. So monitor these sugars and feed the babies. Yes.
When you're saying hypotonia, are you referring like flex?
No, just kind of like.
Right, like that you want them like this, but they're coming in.
So the baby, and when we go over like thermoregulation, babies need to be flexed. This is how they maintain their body temperature. So term babies are able to do this, where preterm do not. But also, if your sugar's low, you're just limp, you know? So you want to monitor the sugars, and they'll say every 3 hours, and the baby needs to make sure that they eat, you know? So you can have a really nice sugar. Oh yeah, the kid's sugar is like 80 at delivery, and then the next half an hour, it's 20. It just whoop, drops. So you want to make sure that you monitor them. Respiratory distress syndrome, also known as RDS, it's impaired or delayed surfactant. That's the key factor to this. So it's seen most often in preterm infants because they haven't had a chance to produce it. Hypoxemia occurs and causes metabolic acidosis, and both can cause pulmonary vasoconstriction. Okay? So newborns have tachypnea, they have nasal flaring, they have contractions, cyanosis, and grunting. So the way to avoid this, if you can, is avoid preterm delivery, and then administer surfactant at delivery if needed. So how do you avoid preterm delivery? Make sure you take care of yourself, make sure you go to the doctor. If you're feeling contractions or not sure, go in and get checked out, don't wait, that kind of thing.
And how do they assess that?
So they would intubate the baby at delivery and give it through the AT tube.
And it's just like serum?
Like a mist. Yeah. So it's some people can't, and they go into preterm labor, it just happens, no rhyme or reason. Others, you know, if you have extra habits that can cause preterm labor. I mean, who knows? People who don't have any, you know, drug, alcohol, or smoking use go into preterm labor, and then people who do go into preterm labor. It's, you know. Meconium aspiration syndrome, right? So this is a response that the meconium, passing meconium in utero happens because of a stressor to the baby, and it causes them to relax and they poop. So if mom has, you know, meconium stained fluid, baby had, you know, bowel movement in utero. It's thick, tarry, like a greeny color. It can stain their skin. It can stain their nails. It can stain their umbilical cord. And the longer they are in it, the more green or yellow they're going to look when they come out. And the vernix that's left on the babies will actually be stained like a yellow color. Okay. Meconium aspiration kind of affects the post-term babies, and those with prolonged labors. Aspiration occurs or can occur and obstruct the airways. So that's why it's important when babies are, meconium fluid, have neo at delivery, the baby comes out and it's not crying, don't stimulate it. Suction first and get what you can out. If the kid comes out crying, then you observe. So we just want to watch the amniotic fluid, suction, and then, observe the babies and see how they go. Okay. Transient tachypnea, or TTN as it's called, is seen often in infants born via C-section because they don't have that squeeze. They don't get that chest squeeze as the other babies do during vaginal delivery. When babies come out vaginally, they get squeezed, their chest, gets constricted, and then it recoils. So all that fluid that's in their lungs gets pushed out. Well, with a C-section, you don't have that. So they have more of a chance to retain some of that fluid. So you may notice that they're breathing a little bit faster. So, check a pulse ox on them. Respirations for a normal newborn are 30 to 60. These kids are 100 to 140. All right, so we want to make sure that they're pulse oxing okay. We want to observe them. You're going to be giving these babies oxygen, respiratory support if needed, IV fluids. This kid is not going to eat by mouth because they will aspirate. They just can't do it. So whatever you can, to give them through their IV, fine. If you need to tube them to give them a feed, fine, but nothing by mouth. Okay? For how long? They just have to transition themselves. Until it comes out. Yeah.
Aspiration is normal.
They're- Well, you're not gonna see them, no, you don't wanna see them. So, you'll see, if you've ever seen a C-section, the incisions are made real small, and they're trying to mimic that squeeze to get as much as they can out. Now granted, the kid, Neo is at delivery, all C-sections, so the kid comes out, and for whatever reason, they feel like they're a little bit juicy, they have a little bit more. They can go down with a suction catheter and suction whatever they can out. Or, you're stimulating the baby and them crying is actually getting them to kind of get that fluid out. But you may have some left over, some residual. So in the babies that have more than just that little bit, you're gonna see elevated respiratory rates. You don't want that. It should be 30 to 60 no matter what. Sometimes, you assess them, okay, they're like 72, all right, give them a little bit of time. They just need to transition. But the ones that come out and it's quick, like that, no, they may even be monitored.
So if there was like a question where it said an expected finding for someone with this, would it be like freckles?
No,
No?
they're breathing fast. Yeah, they're just breathing fast. So, you just, maybe with pulse ox, they may have some kind of retraction, they may have some, they're trying to catch their breath and they're just not doing it because they can't get in that oxygen enough, so they're breathing faster. But you might not necessarily hear crackles on them. Good. Newborn infants and diabetic mothers. So this is mom with a long-term history of diabetes or gestational diabetes, it could be either or. Hypertension is common, it's like best friend with diabetes. So most likely, if you have long-term diabetes, you'll probably have some kind of vascular issue as well. So you'll see a lot of hypertension with these patients. Increased maternal glucose can lead to macrosomia in a baby. Whether or not you watch your diet, your sugars are controlled, you can still end up with a macrosomic baby. So if they note that, Mrs. Smith, looks like you're gonna have like a 9+ pound baby, that a C-section might actually be better for you than trying to go vaginally with such a large child. Yes.
This condition is common with these patients. Who is the patient? Is it the mother?
The mother. Yeah, with the mom. So if you ever, especially with the elder population, if you guys ever go into the homes and you see people who have diabetes, most of the time they'll have some kind of cardiac or vascular issue as well, because they're literally like this together. So uncontrolled hyperglycemia through pregnancy can actually cause heart defects. It can cause fistulas in the babies. It can cause CNS anomalies. It can cause issues for mom as well as for baby. So it's important for her, watch your diet. You know, if you're on an insulin regimen, take your insulin like you're supposed to. Some are like, you know, moms are like, oh, I can't stick myself, I can't do insulin. They offer glyburide to some of the moms, which is a pill. They can take that, and hopefully that controls their sugar. And if not, worst case, then yes, you do need to go on insulin and, you know, just kind of deal with it, really, because you don't really want to risk your life or risk your baby's life, you know, if you can help it. So these kids also have an increased risk of respiratory distress syndrome, you know, because of everything that's going on. Neonatal sepsis. So this is a systemic infection of bacteria in the bloodstream, and it can be from things like staph aureus, E. coli, influenza, GBS or group beta strep. So babies will show poor feeding, vomiting, diarrhea, and lethargy. Later on may show cyanosis, jaundice, or hypothermia. So with GBS, if you're GBS positive, you rupture your membranes, call your doctor, get in, and start your antibiotic, you know, treatment. So they will usually give mom like an ampicillin every 4 hours until delivery. And if she, you know, is allergic, you know, to the penicillins, she can get something else. So as long as she gets treated, the baby has less of a chance of picking up something as it's going through the birth canal. Newborn effects of maternal substance abuse. So babies can be born with various physical and neurological issues. They may actually have NAS, which is the neonatal abstinence withdrawal, narcotic withdrawal. Moms may be malnourished, so babies may be on the small side. They can have congenital anomalies. Cocaine can actually cause your placenta to abrupt, so it detaches from the uterus. Fetal loss, maternal hemorrhage, loss, you know. If mom has a history of drug use close to that time, or she used, they will put a little plastic bag on the baby once it goes to the nursery and try to collect a urine specimen to see if there are any levels, you know, in the baby itself, and, you know, see if they have to do any kind of treatment to ease the withdrawal symptoms, because the baby will have them too. Question? Yes.
Can you go over this pathologic jaundice and episiotomy?
Yeah. Your pathologic is with the RH. So if you're saying if mom, like in me, so I'm RH negative, okay? So my first baby was RH positive, okay? So, and I didn't get RhoGAM, I didn't want that stuff, I'm fine. So as my baby delivered, a little bit of that blood got into my blood. So my body now made antibodies against that. So I have baby number 2 in my belly. So my body now thinks that that baby, that's positive also, is foreign. Has to get rid of it. It's a virus, get rid of it. So I'm gonna start making antibodies against that baby, and my body's gonna try to reject it. It's gonna try to kill it off. So by doing that, it's gonna start breaking down the baby's blood cells. And that causes issues with the baby, the pathologic jaundice. So moms that are RH negative, that have had in like that exposure, and the babies that they have that are RH positive, they will have that pathologic jaundice because my body tried to get rid of it. That's what that is. The other one is the baby is doing it because of immature liver. Does that make sense?
Yeah. Thank you.
Yes.
So, with regards to preterm and babies,
Preterm
yeah, preterm and term babies,
Yeah.
hypotonic and the muscle flexing and flaxseed. I mean, which one goes with preterm or?
So the term babies, you want them flexed, okay? Flexion will help maintain their thermoregulation, so they're gonna maintain their temperature. By doing this, I show you I have good muscle tone. So that's what you want with a term baby. With preterm, they don't have that control, so you're gonna see more of this. So they have lower body temperature, so they need to be monitored closer, and their muscle control is not that great.
So this one,
This
is
is-
that a hypo?
This, yeah, just kind of like, limp, I don't have much tone, it's just not, I'm just trying to hang it out.
Like you have with hypoglycemia.
Right, because my sugar is so, like, your sugar
Oh.
drops so low, and you can't even function, right?
Yeah, what,
Yeah.
we were on the first slide about the rupturing of membrane,
Uh-huh.
the nitrogen paper, you said, the loose color, the dark blue color, that would indicate that was.
The litmus paper,
Yeah, litmus
so, the nitrazine paper,
Right.
when mom comes in and she says, I think my water broke, they have those 3 tests that they do. So the first one is that paper, so you get a little sample and you touch the paper and it's gonna turn a dark blue. That means it's positive. The second test they do is a speculum exam, and they
What's
look,
it?
a speculum exam. So they put a speculum in the vagina, and they look to see if there's a collection of fluid in the vagina, and that's known as pooling. So it's a little pool of fluid, okay? So if you see that, then it's positive pooling. And then the third test they do is called burning. So you take a sample of that fluid, you put it on the microscope, the slide, put it under there, and if you see what looks like a fern leaf, that's known as ferning, and it's positive, and yes, she's ruptured. If there's no ferns, she's not ruptured, okay? If you have like blood in the vagina, like if you have it on the swab, and you touch it to the litmus paper, that can turn it blue too. So, I mean, maybe she thinks she broke her water, and it's just increased vaginal discharge, who knows? Or maybe she even peed herself, sometimes that happens. And women think they broke their water, but it's actually just urine. So, that's why they do those 3 tests to make sure, because you can't go just by the nitrazine paper. Okay? Any other questions? You good? I'm gonna put the camera. Oh, you're practicing?
See if they won't practice.